Hi guys, my name is Sam, a clinical embryologist working in a private clinic located in Tokyo, Japan. And my career as an embryologist is just 30 years. The first slide shows the economic circumstance surrounding Japan LT. Since 2022, public health insurance uh, has been launched in the field of LT, and the basic step of LT, namely control ovarian hyperstimulation, ovum pickup, insemination, embryo transfer, embryo culture, plating towing, assisted hatching, and a number of optional treatment, namely hyaluronic acid enriched embryo transfer medium and artificial oocyte activation are also included in health insurance treatment. Furthermore, since February 2024, these optional treatment were defined as advanced medicine. So since the health insurance has studied a number of artificial oocyte activation reagents were have been were studied to sell from a number of companies. So we can get a number of AOA reagents. So since that time, a number of Japanese embryologists are bothering which reagents should be chosen for each of LT cycles. So today I'd like to talk about the understanding and the practice of oocyte activation. The subtitle is the best choice for a clinical application. Yeah. I'm sorry, the first slide is slightly complex. This slide shows the mechanism of oocyte activation during fertilization. After penetrating the sperm through the zona pellucida, the plasma membrane of sperm and egg are fused. And after that, sperm factor, namely PLC zeta, come into the ooplasm. And then the G protein structure is confirmed, changed, and as a result, phospholipase C is activated, and furthermore, subsequently, phospho inositol diphosphate is hydrolyzed, and IP3 and D-acylglycerol is produced. The produced IP3 bind to its receptor on the surface of endoplasmic reticulum, and this is a trigger of calcium oscillation. This picture shows the sperm of Grabzospermia. Its characteristic is first various morphological abnormalities, and it's impossible to get a normal fertilized zygote. Furthermore, due to phospholipase C, the sperm factor is lacking in this sperm. As a result, it's quite difficult to get a normally fertilized egg even after sperm injection. However, from the genetic studies, it's known that at least at the chromosomal level, the frequency of structural abnormality is low. But such globospermia is very rare cases. In most of fertilization failure cases, in ICSI, it's not so easy to detect in the first ovum pickup trial. This slide shows a number of methods to artificially activate not only human but also other animal oocytes. The upper three methods showing in red color, calcium ionophore A231S7, ionomycin, and strontium chloride are available in human LT in Japan. And these three reagents, namely strontium chloride, IP3 injection, PLC, zeta messenger RNA injection, and zinc sparkling curator, namely T-pen treatment, induce calcium oscillation. This slide shows the mechanism of calcium ionophore to activate the oocyte. When oocytes are treated with calcium ionophore containing solution, calcium ionophore can penetrate the plasma membrane very freely. So the calcium ionophore molecule come into the plasma membrane of oocyte by the calcium ion, and then transport from outside to the inside of the ooplasm, like this. Here is magnificent figures referred from this paper. As I mentioned, the ionophore come into the plasma membrane, bind the calcium ion, and move from the outside to the inside of the plasma membrane and release the calcium ion like this. And after releasing the calcium ion, ionophore molecule, a part of calcium ionophore molecule come into endoplasmic reticulum, and it's a storage of the calcium ion, and bind the calcium ion again, and release the ion into the oocyte plasma. This is a mechanism how the calcium ion concentration in the plasma membrane is increased by calcium ionophore. This slide shows the difference of two different ionophores, namely A231S7 and ionomycin. First, one molecule of A231S7 or A231S7, its name is so long, so I'd like to abbreviate it as A, okay? One molecule of A can bind two calcium ions. On the other hand, one ionomycin molecule can bind just only one calcium ion. However, the selectivity of calcium ion is higher in ionomycin rather than A. Namely, frequently A molecule bind not only calcium ion, but also other divalent metal ion like zinc, magnesium, and so on. And if albumin is supplemented in the basic solution, the efficiency as an activation reagent is decreased in A, but activation efficiency will not be changed in ionomycin. But however, when EDTA is supplemented in the basic medium, both of A and ionomycin, the efficiency to activate the oocyte is reduced. Furthermore, during storage or during the treatment, if the solution is exposed to strong light, activation efficiency is also decreased. So it's necessary for embryologist to take care to light down. Yeah. By the way, as a result, which reagent A231A7 and ionomycin, which is more effective on human oocyte. It's the most important point. This paper, here is a summary of this paper. Namely, in mouse and human oocytes, activation rate is stronger in ionomycin rather than A231A7. Furthermore, in mouse, embryo development after artificial activation, development potential is higher in ionomycin rather than A231A7. The other group, the Chinese group, also reported in human. They reported that activation is higher in ionomycin than air. And furthermore, embryo developmental potential is also better in ionomycin rather than A. Next, I'd like to explain about the precise mechanism how strontium chloride induces calcium oscillation. But as shown here, its precise mechanism is unclear. But the strontium chloride molecule come into the ooplasm through the calcium channel. After that, it's not well known, but indirectly, the strontium ion activate the IP3 receptor on the surface of endoplasmic reticulum and induce the calcium oscillation. Here, as a clinical embryologist, it's very necessary, which is better to artificially activate a human oocyte using strontium or A231A7. For the trial reported in Human Reproduction in 2018, that all of the parameters, namely percent of 2pm2pb, birth duration, clinical pregnancy rate, and delivery rate, in all of parameters, strontium was better than A231A7. But actually, I have slight doubt in this report because in this paper, low fertilization rate after ICSI and severe male factor infertility are included in this study. However, in control group, normally fertilization rate is quite higher, about 60%. So I have a little doubt, but in all parameters, strontium is better than A. So this result may be reliable. Next, this is a report in mouse comparing strontium chloride and ionomycin. In ionomycin group, the oocytes are treated with 5 micromolar ionomycin for 5 minutes. In strontium group, the oocytes were treated 10 micromolar of strontium for 2 hours. Right? As a result, all of the parameters, namely APN formation rate and burst stress, blastocyst formation, and POPs delivery rate, in all of parameters, strontium was better than ionomycin. This is a report from the Japan group. Next report was this study was performed in cattle. The male et al. Compared single strontium treatment, ionomycin single treatment, and combination. A combination group was composed of 3 groups, namely ionomycin plus strontium treatment, ionomycin plus D means 6-D-methyl 6-D-methylaminopurin. It's a 6-D-methylaminopurin, the MAP kinase inhibitor. Yeah. A part of oocytes were treated with this DMAP for 3 hours, right? As a result, in all of parameters, strontium chloride was better than ionomycin. Furthermore, combined treatment, including all of 3 groups, resulted in better results than strontium chloride. This slide shows the summary so far in human. First, when compared strontium and A2317, strontium chloride was superior for the trial, and there is an RCT trial in human. And when compare the activation rate, ionomycin versus A2317, ionomycin was superior. There was poster reporting ESRAM. And when compare the strontium with ionomycin, there is no paper in human. But in animal models, it seems that strontium is better than ionomycin. From these results, when human oocyte is treated with activation reagents, when the oocyte is performed as a rescue AOA, namely, oocyte is treated with oocyte treated 5 to 6 hours after spam injection. I think it's better to choose the ionomycin. It's because in general, human clinical EXE is performed around noon, for instance, between 11 to the 1 o'clock p.m. After culture 5 to 6 hours, it will be in the evening. In the evening, it's quite difficult to treat the oocyte with strontium chloride because it takes 2 hours or longer time. So I think it's better to choose ionomycin. And in LAF, namely recurrent activation failure cases, namely in the first trial, activation rate was very low. And in the second trial, I think it's better to choose strontium chloride just after 15 to 30 minutes after spam injection. Then it's possible to culture the oocyte for 2 to 4 hours. It's acceptable because treatment can be finished within our working time. And in the case of severe RAF cases, so namely in the previous cycle, when oocytes are treated with ionomycin or strontium, however, after the treatment of strontium or ionomycin, there was no PN formation. In such severe case, I think it's better to treat in combination ionomycin plus 6-D-methylaminopurin or ionomycin, strontium, and this 6-D-methylaminopurin. But actually, there is less report in human, so it's necessary to get the approval in the ethical committee. Well, now I'd like to show you our clinics data, verification of the usefulness of artificial activation treatment with ionomycin for oocytes predicted to be unfertilized after ICSI. Namely, after about 4 to 6 hours after spam injection, second polar body is extruded. If that, however, in normal unfertilized oocytes, we can detect each of oocyte will result in fertilization or unfertilized by detecting the presence of the second polar body. So in the evening on the day of ovarian pickup, I think it's possible to rescue the predicted unfertilized oocytes after ICSI. Background. The incidence of the complete fertilization failure in ICSI is about 5%. And except of special cases such as globospermia, fertilization failure cannot be predicted in the first ART cycle. So the aim of this study is to verify the effectiveness of ionomycin treatment on activation of oocyte predicted to be unfertilized by observing the second polar body extrusion 4 to 6 hours after sperm injection. And the measured indicators are fertilization, developmental potential up to prostosis, and clinical outcome after embryo transfer. First, I observed the second polar body explosion time every 2 hours after sperm injection. We performed this study about 15 years ago. At that time, no time lapse is equipped in all of the ART lab. So we observed very manually every 2 hours. As a result, after 4 hours after sperm injection, about 86% of oocyte extrude the second polar bodies and reached to Alan plateau. From these results, I decided to treat the M2 oocytes without second polar body extrusion at 4, 6, or 20 hours after sperm injection. Here is the materials and methods. After sperm injection, the oocytes are cultured for 4, 6, or 20 hours. After that, the unfertilized oocytes without second polar body extrusion release 10 micromolar of ionomycin for 10 minutes. And after that, the oocytes are cultured for 12 to 20 hours and then observed for the fertilization. And normally fertilized zygotes were cultured up to day 5 to check the developmental potential. In phase 1, we performed this clinical study between December 2009 to June 2019. And in phase 2 was performed from October in 2022 to June 2025. And during this period, especially in the first phase, we cultured the human embryos using the G1-5 medium, very classical medium, from day 0 to day 3. And from day 3 to day 5, the embryos were cultured using this medium. So I mean the embryos were cultured in sequential medium. And on day 1, normal fertilization was observed, and on day 5, total blastocyst rate and blastocyst rates were observed. Here is the result. When in non-treated group, there was no activation rate, normally fertilized oocyte, the proportion of normally fertilized egg was 0. But when the oocytes were treated with ionomycin 6 hours after sperm injection, the proportion of normal fertilization was about 50. And when the oocyte was treated with ionomycin 20 hours after sperm injection, the normal fertilization rate decreased, but there was no significant difference. And when cultured up to day 5, blastocyst rate control means the normally fertilized oocytes without ionomycin treatment. The blastocyst rate was 43%, and in rescued AOA group, when iomycin treatment was performed 6 hours after sperm injection, blood saturation rate was 20%. And 1 day old treatment group, blood saturation rate was almost zero. Yes. Next, I compared the iomycin treatment for versus 6 hours after sperm injection. As a result, proportion of normal fertilization was almost same in between the two groups. However, total blastocyst rate was improved by the iomycin treatment 4 hours after sperm injection. However, in this comparison, there was no non-treated control group. So next, I compared non-treated group with 4-hour iomycin treatment group. As a result, even in non-treated group, 4 hours after sperm injection, about 35% of oocytes resulted in normal fertilization. However, the proportion of normal fertilization was significantly higher in iomycin treatment group. Furthermore, when compared to blastocyst developmental potential, there was no significant difference in total blastocyst rate and good morphological blastocyst rate. Next, I examined the iomycin treatment between 4 to 5 hours after sperm injection, not only the one time, but also 3 times, namely 4 minutes and 30 minutes later, 3 minutes treatment. And in the third treatment, 3 minutes again. It's a mimic of calcium oscillation. As a result, even after 3 steps of calcium treatment, all of parameters, namely normal fertilization, total blastocyst, good blastocyst, all of parameters was not improved furthermore. This is phase 1 of clinical outcome after embryo transfer. In total, including fresh cleavage embryo transfer, fresh blastocyst transfer, and frozen told blastocyst transfer. Here is the total results. I'd like to explain just only the total results. After embryo transfer, clinical proportion percent of clinical pregnancy was 14%, and delivery rate was 80%, and abortion rate was 20%. In phase 2, between 2022 to 2025, especially in day 5 frozen total embryo transfer, the clinical pregnancy rate after embryo transfer was 34%, implantation rate was 32%, and delivery and ongoing pregnancy rate was 75%. Actually, I think this clinical result may be acceptable to perform the clinical application of rescue oocyte activation using iomycin. This slide shows a nucleus state of human unfertilized oocytes fixed 18 to 20 hours after sperm injection. When we examined 56 unfertilized oocytes, we fixed with acid. After fixed the oocytes are stained with acetylocyanine. As a result, out of all of the unfertilized human oocytes, about 32% arrested and metaphase 2. However, about 60% of the unfertilized oocytes arrest at metaphase after second polar body extrusion. So actually, it's impossible to rescue such unfertilized oocytes arrested after second polar body extrusion. This is a picture of human fertilized oocytes arrested at metaphase 2, namely without second polar body extrusion. Here we can observe the oocyte metaphase plate, and here is sperm premature oocyte, chromosome condensation. And in other unfertilized oocyte, we can find first polar body and second polar body. And close to these polar bodies, we can find a metaphase chromosome of the oocyte. And around the position of the center of the unfertilized oocyte, we can find the sperm head formed a metaphase plate. Here is the conclusion. Iomycin treatment can rescue a part of the human oocytes that would otherwise be unfertilized, but their subsequent developmental potential was slightly reduced. It's difficult to rescue unfertilized eggs with second polar body extrusion because there is no other effective indicator. This method is effective to some extent, especially in cases of unpredictable fertilization failure in the first ICSI cycle. Thank you for a long time listening. Here is the last slide showing the acknowledgement. Thank you, everybody.